Alright, I hope this finds you well. This is our last lecture, the second on psychological disorders, and it's primarily going to be focused on the psychological disorder of schizophrenia. Schizophrenia is a mental illness that results from the combination of biological predispositions, such as having genes that predispose you to developing the disorder, and experiences, so things that happen in the environment, and both play an important role. A solid understanding of both aspects is necessary for successful treatment and understanding the causes of schizophrenia. All right, in terms of the demographics, in schizophrenia, it occurs to about 1% of men and women. If you remember back to last lecture, we saw that it occurs about equally in frequency in men and women. However, there are some important sex differences where men tend to show symptoms earlier in young adulthood, so in their late teens, early 20s. Whereas for women, the onset of symptoms usually doesn't come to a decade later, right? And just the fact that the symptoms kind of occur at a typical age and they don't occur until adulthood ends up being some, I think, some important hints as to the potential causes of the disorder. There are some symptoms that are in schizophrenia that are considered acute. They develop quickly, suddenly. These tend to respond more to treatment and prognosis in terms of recovery from these types of symptoms is reasonably good. There are more chronic symptoms that develop gradually and persist over a longer period of time, and the prognosis is typically poor in association with these symptoms. Schizophrenia is a disorder characterized by deteriorating ability to function in everyday life and has some combination of the following: hallucinations, delusions, thought disorder, movement disorder, inappropriate emotional expression. Right? So if you look at all those different categories of disorders, symptoms, cognitive, movement, emotional, right? Schizophrenia is really kind of, it involves a person fairly completely in the disorder, not just some kind of peculiar aspect of one part of kind of their functioning. All right, so in terms of symptoms in schizophrenia, some of them are symptoms of psychosis. They consist primarily of delusions and hallucinations. Delusions are unfounded beliefs. There are certain categories of delusions that are very common in schizophrenia. For example, delusion of grandeur, thinking that you are a particularly important person. Delusions of control, feeling as though somebody outside of yourself is controlling your behavior. There are also hallucinations, which are abnormal sensory experiences associated with increased activity in the hypothalamus, hippocampus, and the sensory areas of the cortex that would normally be involved in that sensation. They can occur in different sensory modalities, but by far the most common would be auditory hallucinations, and often people hallucinate hearing a voice. A second category of symptoms can be described as disorganized symptoms. These include inappropriate emotional displays, bizarre behaviors, and thought disorder, difficulty using and understanding abstract concepts, right, and generally speaking, maintaining what we would think of as a coherent train of thought. And there are symptoms that are considered positive and negative, right? And so on this slide I just have listed negative. I'll go through this first and then I'll talk about positive, right? So what negative here means, it's not negative in the sense of bad, but negative in the sense of something that's taken away. So negative symptoms refers to these symptoms that normally would occur, but you don't see them, behaviors that would normally occur, but you don't see them as much in schizophrenia. So you see, for instance, weak social interaction, right? So social interaction is normal. You see a lot less of it in schizophrenia. People tend not to have friendships, romantic relationships. It's certainly not at the level that would be normal. So this is something that's missing. Emotional expression. There's a lack of emotional expression. If you look at the faces of people with schizophrenia, they often, right, they're lacking in expressing emotion. They have kind of almost wooden looking faces, right? Speech, right? Poverty, lack of speech, problems, deficits with working memory, right? So he said, right, people with schizophrenia sometimes have problems maintaining coherent train of thought. Well, if you have problems with working memory and keeping things active in memory, right, and maintaining attention over a period of time, that could potentially explain some of the symptoms. So negative symptoms are usually stable over time and difficult to treat. So earlier in an earlier slide, we referred to these as chronic, right? Stable. In contrast, the psychotic symptoms, I'm going to back up here, of hallucinations and delusions are sometimes referred to as positive symptoms. Not positive as in good, but positive meaning here are behaviors that are present that should not normally be. So delusions, right? Ways of thinking, beliefs that are present in schizophrenia that shouldn't be normally. Hallucinations, sensory experiences that are present in schizophrenia but normally would not be. All right, and these psychotic symptoms, positive symptoms, are the ones that are described previously as acute, and these are the ones that are usually better treated by medication. All right. Twin studies, like behavior genetic studies we've considered earlier, suggest a genetic component in schizophrenia. Monozygotic twins, so identical twins, have higher concordance rates, agreement in diagnosis than fraternal or dizygotic twins. But monozygotic twins, right, when you look at their rate of concordance, they only have a 50% concordance rate. So if one one monozygotic twin is diagnosed with schizophrenia, there's only 50% likelihood that that their twin will also be diagnosed with the disorder. So there are other factors other than genes that may explain why there is divergence between monozygotic twins in terms of being diagnosed with the disorder. A greater similarity between dizygotic twins than siblings in concordance rate suggests that there might be a prenatal environment effect or postnatal effect, right? So the fact, so dizygotic twins and normal siblings, they both share 50% of their genes, but dizygotic twins are more alike in terms of diagnosis, so they're higher in concordance rate. And that suggests that some of the things that might be going on in the environment happen prenatally. So we'll be talking about that later. All right, so here's just the results from behavior genetic studies, right, showing the degree of concordance, right, in diagnosis between people of differing relationship and of importance to us. Down here we can see that monozygotic or identical twins have a concordance rate of about 48%, which is much higher than dizygotic twins, which is at 17%. But notice what we said earlier in the previous slide, that siblings, right, who like dizygotic twins, they share 50% of their genes, but they only have a concordance rate here of 9%, right? And so the idea is with these dizygotic twins, maybe there was something that happened prenatally because they shared, right, an environment in the womb that normal siblings wouldn't, that accounts for these dizygotic twins being more alike than normal siblings. Okay, so adopted studies with adopted children suggest a genetic role in schizophrenia, but prenatal environment of the biological mother cannot be discounted. We saw some of that evidence just in the previous slide. The attempt to link adult onset schizophrenia to an identified gene have provided inconsistent results. There are a few genes that have been identified as being related to schizophrenia, but no single gene conveys very much risk at all. Research has identified a gene for child onset schizophrenia, but these cases are much more rare. Schizophrenia most likely depends on a combination of genes or different genes in different families. And this is not just the case in schizophrenia. This is really sort of where we're at, what seems typical for most psychological disorders, that they do have a genetic component, some more than others, but they don't have single kind of dominant genes. All right, so we'll talk about several different ideas for what causes schizophrenia, right? And one of the things to keep in mind, so there's different hypotheses. These are not necessarily mutually exclusive. More than one of these can be right. In fact, it's almost certainly the case that to some extent there's evidence supporting all of them. All right. So one idea about a cause for schizophrenia is called the neurodevelopmental hypothesis. It suggests abnormalities in the prenatal or neonatal development of the nervous system would account for schizophrenia. When you examine the brains of patients that go on to develop schizophrenia, according to this hypothesis, the disease leads to subtle abnormalities of brain anatomy that lead to major abnormalities later in life in behavior. And these abnormalities could result from genetics, things that happen in the environment early on, like difficulty during complications during childbirth, or a combination of both. Some of the evidence supporting the neurodevelopmental hypothesis include that there are a number of different kinds of prenatal or neonatal difficulties that are linked to greater risk of later developing schizophrenia. We'll talk about a few of these. And also that people with schizophrenia have minor brain abnormalities, but you look at when they what the origins of these abnormalities are, they appear to be things that would happen during neurodevelopment, like failures for neurons to migrate in an exactly normal way. So things that happen very early on in the development of the nervous system, right, during prenatal development. Also, abnormalities of early development could impair behavior in adulthood, right? So the idea in general with the neurodevelopmental hypothesis is you get these abnormalities that are present in the nervous system, but we don't see the symptoms of schizophrenia until young adulthood. And it's quite possible, right, if you think back to our chapter on neurodevelopment, because the brain continues to develop in major ways all the way through young adulthood, right, where the brain is still being myelinated, especially through the frontal lobe, that the kind of the finishing of the major development of the brain might be what allows these early subtle behavior neuroanatomical problems to become apparent. All right, so some of the prenatal risk factors that increase the likelihood of the development of schizophrenia include poor nutrition of the mother during pregnancy, premature birth, a low birth weight, complications during delivery, right? Like when a child gets the umbilical cord wrapped around their neck and doesn't have oxygen for some period of time during the delivery. Also, infectious disease of the mother are things that can increase the likelihood of developing schizophrenia. Head injuries very early in childhood are also linked to increased incidence of schizophrenia. There's some interesting stuff in terms of blood type. When the mother-child blood type, when there are differences in blood type, certain differences increase the likelihood of schizophrenia. So, for example, if the mother has Rh negative blood type and the baby is Rh positive, the child has about twice the probability of developing schizophrenia, and it's thought that in part this could result from an immune response, right? So during prenatal development, with this combination of blood types, the mother's immune system can mount an immune response essentially to the child. So this is also associated with an increased risk to the development of schizophrenia. So certain viral infections like the common seasonal influenza may be an alternative or supplement genetic influences. So I think the right way to think about this is just one more of these risk factors that is especially important if it happens during a critical time in neurodevelopment. There is a thing called the there shouldn't be an ED there. It should just be season of birth effect, refers to the tendency for people born in winter to have a slightly greater probability of developing schizophrenia. It's more pronounced in latitudes that are farther from the equator, where you get greater differences in terms of weather and a more pronounced infectious disease like a flu season. It might be explained by complications of delivery, nutritional factors, or increased likelihood of viral infections that occur at certain times of year. So schizophrenia is associated with mild brain abnormalities, not huge differences in neuroanatomy. The strongest deficits, biggest differences, right, when you go looking for them in terms of the brains of people who develop schizophrenia are found in the left temporal and frontal lobe of the cortex. One of the effects that can be seen as kind of a global reduction in neural tissue that results in larger than normal ventricles in patients with schizophrenia. Remember that ventricles are the fluid filled structures, and so when you have neuron loss kind of globally in the brain, one of the easiest ways to see this is that the ventricles become larger because they kind of fill out to take up the space that is no longer being taken up by neurons. Areas that mature slowly, such as the dorsolateral prefrontal cortex, are places where you see greater differences, and not just in neuroanatomy, but in kind of functioning in schizophrenia. And patients with schizophrenia have deficits in working memory. Remember that working memory is associated with the functioning of the frontal lobes, and the frontal lobes is one of the last areas to develop completely in terms of being fully myelinated. All right. But overall, the abnormalities that are observable in schizophrenia tend to be seen on average, and generally speaking, they're small and they vary from person to person. Reasons behind brain abnormalities are not completely certain, although some might be due to early environmental stresses or genes. Some might be due to substance abuse that is common in schizophrenia. Results are inconclusive about whether brain damage associated with schizophrenia is progressive and gets worse over a lifetime or not. All right, so class of drugs that are used to treat schizophrenia and similar psychotic disorders are often referred to as antipsychotic or neuroleptic drugs. Right, so one of the first drugs to treat, major drugs to treat schizophrenia, chlorpromazine, trade name Thorazine, is a drug used to treat schizophrenia that relieves primarily the positive symptoms of the disorder. Right, so remember those are positive. the addition of things that wouldn't normally be there. So like hallucinations and delusions, and these are usually acute, right? These symptoms come on quickly and suddenly. These are the ones that are best treated by medication. But interestingly, right, you have to take this drug for 2 to 3 weeks before you start to see a reduction in symptoms. All right, so right, there are now several families of drugs. A couple major ones used to treat schizophrenia are phenothiazines. Those include chlorpromazine, and butyrophenones that include haloperidol, trade name Haldol. All right, but in terms of all of these drugs that reduce the symptoms of schizophrenia, one of the things that they have in common is that these drugs block dopamine synapses. All right, and here's a graph showing the relationship. So all of these points on the graph, right, are showing different drugs that can be used to treat schizophrenia from those two major classes that we talked about. And what this is showing is that how much of the drug you need to control for schizophrenia is directly related to the dosage of the drug necessary to block dopamine receptors. And what this graph is showing is that, right, the drugs that block dopamine receptors better, you need less of that drug to treat schizophrenia, right? So at least in terms of the reduction of the positive symptoms, the ability of drugs to reduce the positive symptoms of schizophrenia seem to be directly related to their ability to block dopamine receptors. All right, and this led to an idea for what causes schizophrenia referred to as the dopamine hypothesis. Dopamine hypothesis of schizophrenia suggests that schizophrenia results from an excess activity at dopamine synapses in certain areas of the brain. All right. Some of the evidence for this we just saw, that when you reduce or block right, the effects of dopamine in the brain, you reduce the symptoms of schizophrenia. Also, right, drugs that increase the release of dopamine, and we saw this just in our last lecture, right, that there are lots of classes of addictive drugs, especially amphetamines, methamphetamines. When they increase the release of dopamine, you can see a condition called substance-induced psychotic disorder. It's characterized by similar symptoms to the positive symptoms of schizophrenia. So you can see hallucinations and delusions, and this results from taking repeated large doses of amphetamines, methamphetamines, or cocaine, all of which result in the release of excess dopamine. So each of these drugs prolongs activity of dopamine at the synapse, and so this further provides evidence for the dopamine hypothesis. If you just think about it this way, right, if you add excess dopamine, you see psychotic like symptoms in people. In patients with schizophrenia, when you take drugs that reduce the amount of dopamine activity in the brain, you reduce hallucinations and delusions associated with the disorder. And research indicates it's not all of the different receptor subtypes, right? This detail is not so important, but it's a particular type of receptor for dopamine known as the D2 receptor. All right. There are some limitations of the dopamine hypothesis. One is that this is hard to do. To directly measure the amount of dopamine that anybody has in the brain. Attempts to do this based on metabolites don't indicate that people with schizophrenia generally have higher levels of dopamine than normal, just globally in their brains. Again, difficult to do in humans. And it's also the case, I mentioned this, that antipsychotic drugs, when you take them, they block dopamine within minutes, but the drugs don't start to improve symptoms of schizophrenia until 2 or 3 weeks later. So it suggests, right, that maybe it's not so simple and so direct as just overactivity in dopamine synapses causing the symptoms of schizophrenia. Because when you block those, and you can do that very quickly with the drug, it's not as though the symptoms immediately improve. All right, there's different, right? Dopamine is not a neurotransmitter that you find ubiquitously, just kind of everywhere in the brain. There are what are called dopamine systems, certain areas of the brain that use dopamine as a neurotransmitter. And one of them, the mesolimbocortical system, we'll see a slide of kind of where this is in the brain in just a minute. This system is a set of neurons that project from the midbrain to the limbic system, and this is the site where drugs that block dopamine synapses produce their benefits in patients with schizophrenia. Right? So you take a drug that blocks dopamine, like Haldol, it's going to reduce dopamine everywhere, but there's only kind of one specific projection, dopamine projection, that it's thought where it's the blocking dopamine reduces the symptoms, right? So unfortunately, the drugs also block dopamine in other systems, including one that projects to the basal ganglia called the mesostriatal system. All right, and we think back to our earlier chapters, if I was to ask you, right, what's associated with the basal ganglia, hopefully you would remember that it's movement, that Parkinson's disease and Huntington's disease are diseases that affect the basal ganglia. All right, and so taking a drug that reduces the amount of dopamine released here in the mesostriatal system over time can result in a condition known as tardive dyskinesia. It's primarily a motor problem, right? So it's a side effect of taking the medication that is characterized by tremors and other involuntary movements, right? So especially with the early drugs that were developed to treat schizophrenia, right, there were great benefits in reducing the positive symptoms of the disorder, but one potential, right, very consequential negative side effect was the production of this motor dysfunction called tardive dyskinesia. All right, and so here's just an illustration that it is the mesolimbic pathway that's thought to be kind of the key dopamine releasing pathway that that's involved in the reduction of the positive symptoms of schizophrenia. So one alternative way to describe the dopamine hypothesis that would be a little more precise would be, we could call it the mesolimbic dopamine hypothesis of positive symptoms of schizophrenia, right? And right, this is just a more precise version of the dopamine hypothesis, all right? And it states that mesolimbic overactivity is what causes the positive symptoms of schizophrenia, and it's the blocking of dopamine here at these specific sites that reduces just the positive symptoms of the disorder. All right, and here is an illustration of these two pathways: the mesolimbic pathway, right, that is projecting from the brainstem to areas of the limbic system and the cortex, right? So mesolimbocortical system, and its reduction of dopamine, blocking of dopamine, right, at these locations that reduces the positive symptoms of schizophrenia. Also shown here is the mesostriatal system, right? So projecting from the brainstem up here to the basal ganglia and blocking dopamine at these sites is what causes the motor dysfunction of tardive dyskinesia. All right. There have been lots of drug development in the treatment of schizophrenia. So there were a number of major drug types that were developed that are described as second-generation antipsychotics, or sometimes also atypical antipsychotics. These are a class of drugs used to treat schizophrenia, and they tend to have a slightly different profile of effects that go beyond just reducing the amount of dopamine or blocking dopamine in the brain. Right, here's some examples of these different kinds of kind of more recently developed drugs that would be considered second generation or atypicals. And these drugs are all more effective at treating the negative symptoms of schizophrenia, so those problems that are more chronic. These are now much more widely used. They do have effects on dopamine. They do block dopamine D2 receptors, but they have less of an effect compared to those typical antipsychotics. And they tend to have effects in other neurotransmitter systems, including many of them antagonize or increase the activity of 5-HT serotonin receptors. All right, so schizophrenia can't be explained by a single gene or by a single dysfunction in a single neurotransmitter. We've talked about the dopamine hypothesis. It's also the case that there's a fair bit of evidence that other neurotransmitter systems, namely glutamate, may play important roles in schizophrenia. Schizophrenia also, right, the evidence trying to look for the genes that might be involved in schizophrenia, the evidence suggests it involves multiple genes and abnormalities in multiple neurotransmitter systems. So let's talk about that, the second major neurotransmitter hypothesis of schizophrenia, the glutamate hypothesis. Kind of remember back when we were considering neurotransmission, and if you remember anything about glutamate, you might remember it's one of those ubiquitous neurotransmitters. That is, it's found throughout the brain, and it is an excitatory neurotransmitter. All right, and according to the glutamate hypothesis, hypofunctioning, so underfunctioning at glutamate receptors, is the cause of both positive and negative and cognitive symptoms of schizophrenia. Right, and the glutamate hypothesis we'll see in a second here, because the glutamate system interacts with the dopamine system, because the glutamate system is really everywhere. The glutamate hypothesis has the potential to explain why dopamine is dysregulated in schizophrenia. What's some of the evidence that supports the glutamate hypothesis? One is that there's a street drug, PCP. It's also called angel dust. It blocks one subtype of the glutamate receptor called the NMDA receptor. Remember that we talked about this back in the chapter on memory when we were talking about long-term potentiation. So, PCP blocks the NMDA receptor, right? So it decreases the normal activity of the NMDA receptor, and it causes schizophrenia-like symptoms, and it probably more closely mimics a range of symptoms seen in schizophrenia than what you see just with amphetamines or methamphetamine, for example. And as already stated, the glutamate system can regulate dopamine function, so has the potential to explain why there might be dopamine dysregulation in schizophrenia. So another way to say it is that the glutamate hypothesis may be able to subsume or explain the dopamine hypothesis. And interestingly, although there are many genes involved in schizophrenia, the ones that have been identified seem to converge on the NMDA receptor. That is, a lot of the genes that have been identified as conveying greater risk for schizophrenia seem to have something to do with NMDA receptors. Increasing NMDA receptor activity through the direct administration of drugs like glycine also has the effect of decreasing symptoms, right? So there's multiple avenues of evidence supporting the glutamate hypothesis, and I want to end by showing you a video with one of the kind of major researchers in this area. Daniel Weinberger talked.
So how does glutamate relate to schizophrenia? For probably 40 years, most of the work in schizophrenia was focused on dopamine. But because the evidence has increasingly centered around areas of the brain like the frontal lobe and the hippocampus, which are these so-called cortical regions of the brain, there's been a lot more interest in what are the neurotransmitters that are critical for how the cortex works. And in the cortex, the main neurotransmitters are amino acid neurotransmitters like glutamate and GABA. Glutamate is the principal neurotransmitter of cells that communicate across long distances in the brain, such as across cortical regions and from the cortex down into the spinal cord or out into the rest of your body. And glutamate is a critical molecule for the function of the cortex. Based on those observations, there's been a lot of research now to look at glutamate. And there's a pharmacological model of schizophrenia based on the blocking of certain glutamate receptors, a particular glutamate receptor called the NMDA receptor, which is N-methyl D-aspartate receptor. And there's a drug, a street drug, called PCP, which blocks this receptor. And associated with the use of this drug is a psychotic-like state. Not just a psychotic state, but also change in cognitive function, change in the ability to pay attention, distraction, which have certain features of schizophrenia. So there's been a pharmacological model of schizophrenia based on glutamate. Turns out, so far, most of the genes that have been found that relate to schizophrenia, particularly neuregulin, dysbindin, COMT, some other genes like GRM3, AKT1, calcineurin, etc. Many of these genes seem to impact on the function of glutamate in the brain. So glutamate may be a final common pathway that many of the biological risk factors impact upon to translate into the kind of behavior and brain function that we see in schizophrenia.
All right. Okay, so that's where we're going to end our lecture on psychological disorders and schizophrenia, and it's also where we end the semester.